Good evening, everyone. I welcome you all to this ECD webinars series. This month being the Autism Awareness Month, we are conducting session on related to the topics of autism over the lifespan from childhood and infancy up to the adulthood. ECD Forum, I just want to mention a few things about ECD Forum. Ours as a ECD Forum is a body formed by developmental pediatricians. We are all friends. We belong to one batch. And we are from Pan India. We are from different states. We have formed a association, ECD Forum. And in this banner, we are conducting several training sessions and we are learning from each others. This is a little bit introduction. We'll know about the body soon. We have a president, Dr. Nilanjan, who will be giving a talk today. We have Dr. Vishal Vaidya and Dr. Harikah is our secretary and myself, I'm the treasurer of ECT Forum. We have our IB members, Dr. Ketaki and Dr. Reena with us. So welcome everyone.
Thank you, ma'am.
Yeah. Thank you. So today we'll be dealing with topics related to autism from infancy up to the adulthood. So let us begin with the younger age ones. The first one being question being nowadays many parents are there. That's like pan India, pan world has become a smaller place, and we are getting families with multilingual persons. So mother belongs to one state, or the father belongs to another state, and we have multiple languages. Even classical example, even my family is a bilingual. I speak Telugu and my husband speaks Hindi. Naturally, every parent would be having an apprehensions like if you have two bilingual or multilingual going on in one family, does that impact the speech development in a child? Even for a normal kid, you will have apprehensions. So many times the elder ones will be saying, speak in only one language, speak in only one language. The child will get confused. So is it true? More so in autism, what is the impact they have on the autism? So today, Dr. Harikah will highlight all these aspects. Dr. Harikah is a developmental pediatrician based at Bangalore. She is the secretary of ECD Forum. She runs her own child development center, Sprouts. So let us begin, Dr. Harikah. Welcome, Dr. Harikah. Over to you. I'll share
Thank
the
you,
screen.
ma'am. Yes, ma'am. So today we are going to talk about multiple languages in the households, which is a common question that every parent has. So it's a very simple thing, and right now there's a lot of research happening on bilingualism that is being followed at home. Next slide, ma'am.
Yeah.
So, what is bilingualism? That is able to talk two languages in everyday life. So, if it is more than three, if it is three, it is called as trilingualism, and more than that, it is called as bilingualism. In 2007 census in India, it has been shown that 26% of the Indian population are bilingual and 7.1% is trilingual. And if you see, the more multiple languages are used in households, in urban households, rather than compared to the rural areas. But with the given updates from 2011 and 2026, I think the numbers are going to be very high. So, from the recent advances that happened to be in 2011, the numbers are very low. So, in any given state, if we see, bilingualism is very common because the child speaks a native language at home, and English is being a common language in the school. Next slide. So this bilingualism does not cause any speech delay, or it doesn't worsen the language delays in autism. This is from the latest research that has been published. And autistic children can very comfortably learn more than two languages. Their issue is not to learn the language, but their struggle is to process and social communication and generalization. So, limiting to one language is actually not necessary until unless there's a specific challenge that will be discussed in the next slide. And if at all you want to talk two languages, there are going to be a structured format that we have to follow that will make it very easy for the child to understand and learn the two languages simultaneously. Next slide. So there is no significant difference in the language development outcomes when multiple languages are introduced. Some bilingual autistic children show better social communication skills like gesture use and perspective taking, and then their cognitive flexibility is better, and it is stronger because switching is a problem that we see. Transitions are a problem. So when we do it at home at a very young age, transitions will become easier for a child. Next slide, ma'am. So why it actually matters very specifically in India? Because we speak in native language, and it has a lot of emotional connect to it, and there's a lot of family bonding with it. For example, when I see children coming with illness, the mother is very comfortable when she talks in her native language. Or whenever you have a pain, it is always better you speak in your native language. मुझे इतना दर्द हो रहा है, मुझे नींद नहीं आ रहा है, 3 दिन हो गई. So you connect better. So in India, we are full of emotions, and our family bonding is based on the native language. So, so please do not limit with the one language. And then, if a child, most of the children are preferring English as their primary language, which will affect the bond with their grandparents or with the nannies. And it's always best if a parent speaks to the child in their native language. It will improve the emotional and linguistic output. Next slide. Next slide, ma'am. Yeah. So, if you're forcing a child to speak only in English because they pick it up from the screen time and all that, what happens is they have reduced quantity and quality of their interactions. The parents have a lot of stress because they're not able to connect with their children, and then very less natural communication the child can develop. Next slide. So when you have to stick to one language, that is when the child has very minimal verbal output, or there is a significant receptive language difficulty, or caregivers are not comfortable in switching, and they confuse the child by using a lot of grammatical context into it. And if the parents are not able to clearly structuredly go with bilingual, then you'll have to switch to single, and then once the child is comfortable, then slowly we can introduce another language. So the goal here is to have clarity and consistency, and not by removing a language. So what are the practical guidelines we can follow? So first thing for any parent is please use the language that you're most comfortable with, where you can express your emotions the best. And one more thing you can do is one person, like mother can use Hindi and father can use English. And then what you can help the child understand is repeat across all languages. So if our child wants banana, say banana and kela, or artipandu, or something like that. So you are using you're showing an object, you're telling in both the languages. So the child is actually learning a functional speech. You're not randomly telling, you're showing it and you're telling. So the child will have a correlation and a visual stimulus on that. Next slide. So sometimes, when you're throwing a ball, okay, so you're telling throw, and you can use other local language also, Veyu in Telugu. Sometimes you don't have to translate because the child will understand it from the action. So you don't have to literally translate everything. Few things they will also learn from generalizing and understanding from that function of that action. So in therapy, it is fine if the child is speaking in English. Not necessary that you should carry the native language in the therapy. Many parents come to us telling that, Madam, we speak only Bengali or Hindi in our home, and I don't know if the child will understand. Do we have to have a Bengali therapist? Not required. If you're very clear with communication and language are two different things. With communication, you can do with an action. For example, I do this, I can understand that I'm having a headache instead of telling a headache or sirka darad. So it should be more of a communication than a language. So a language will not affect a child in a therapy. So reassure the parents not to drop, and then just to make the child comfortable in the school, let them not pick up English or any language that is actually required. they can learn. And if they learn one language, and when you are using the words in the functional actions, they can pick it up slowly. There is no problem. And for children who are using AAC, you can have two labels with that, so that it is very easy for them to have a receptive understanding. Maybe they're not able to express, but reception will definitely help them out. And please speak in your native language. That is very important. And a meaningful interaction is a communication, not language, and an emotional connection that comes only with a native language. So parents, please use your native language, so your child will learn expressions from you, and then the bonding will improve. And be consistent in communication. So it is not that 2 days you're trying to talk your native language, and then it is 2 weeks of English, and again you're trying. It should be consistent across all days. And then it is not the number of languages that matters, it is the communication and your expression and your emotion that matters. Next slide. So how do we introduce two languages step by step? The first is, like as I told you, communication is important. So focus on the intent, not on the perfection. So first you tell one word, and then slowly tell the other word also. So start with one or two words, open and close. Muyu, teru. So open, uh, teru, and close, muyu. So you're using both the words simultaneously, so the child will understand. So start with a few words that the child is very comfortable, he knows, open, close. Start with correlating that with a native language. Next slide. Then slowly include two words. So if a child is comfortable with the open and close, and when you're having a conversation in English, instead of open, the colloquial word is colo. When you're talking in English and the child says colo, you don't have to correct him. That's fine. Give him that comfort. So he will be using both the languages. That's absolutely fine initially when the two languages are introduced. Next slide. So two word combination. So once the child is very comfortable with one word, so you can combine two words. For example, you can say want ball, ball chahiye. Okay. So similarly, you're introducing two words just like the one word. So don't mix grammar into this. Mujhe ball abhi de do. Instead of that, ball de do. So just keep two words. That is enough to start with. Next sentence. So, like for sentences and pragmatics, start with simple sentences. For example, like when you are saying greeting someone, good morning, and we are saying namaste, both together. Then we are saying, how are you? Kaise hai aap? So when we are doing both, the child also gets comfortable and he will start using both, or sometimes he can pick one language of his choice. Next slide. So, in activities, how can you include this bilingual? So, for example, you're playing with bubbles. So, you want to open the lid. So, you're telling open, colo, and then you're blowing bubbles and you're looking at him and you're asking more, jada chahiye, aur chahiye. So, we are just asking, like, we are not telling the same thing in the same language, but one time we are telling in English, one time we are using the native language. So when you're writing goals, please do not write that the child can speak only English. So instead of that, make sure like in your goals you write that the child will be using one or two languages, one or two words of any other language, and then slowly generalize the meaning of that words across all the languages that the child knows. So parent should speak the strongest language that they know, and avoid overcorrection, and then expand the child's utterance. So positive reinforcement is required. And then so as I told you, want ball, ball chahiye, you see both together. Next slide. So common mistakes to avoid: forcing only English therapy because the child is comfortable. It's okay, the child will generalize. And then correcting the language choice constantly. So the child will shift between languages, that is absolutely acceptable. And then don't force a child to use grammar. he's going to make different mistakes like you instead of me. All these things, that's okay. As far as the child is uttering, let him utter. And then over a period of time, slowly, once the child gets into the comfort level, we will correct it. So, and please do not ignore the home language. That is the foundation, and that's very important. And as I told you, like for children on AAC, please use dual language and then attend parental workshops, and visual boards also. Please have two words in it so the child will have a generalization. Thank you. I can take any questions if you have.
Thank you for the wonderful session, Dr. Harikah. The key is like even if the child is using any language, encourage that instead of being fixative to one language, whether it is most often it's with the English. Many people think that English is easy, so let them speak in English, and they discourage when the child starts speaking in the native language. That is very wrong perception. And one more thing is when they are able to speak in sentences, children often mix up both the languages. That is fine. You have to accept that. Whenever they are mixing up two languages, it's fine to accept that. They will learn to translate at a later age. But initially, you have to accept even a mix up of the languages. If you have any questions, you can unmute yourself and ask.
I'm Parimal Das speaking. Can you hear me?
Yes.
Yeah. So
Yes.
you talked about that bilingual things. I was trying to understand, and as you know, probably that we've met in Calcutta, Nilanjan and are in research collaborations with that. So with that interest, I joined, and two of my PhD students also joined. You talked about bilingual thing. That's fine. I to understand it. But if in a situation, it boy, a kid can learn more than two, that's perfect, right? We can pursue them, or it will be more load on that. Is there any
No,
comment in
sir.
that case?
There is no upper limit for the child to learn languages. As far as the child is comfortable, please go ahead, because that will help in the other areas of transition also. As much as the child is able to learn comfortably, please go ahead and teach any number of languages.
There is no problem. Why I'm asking, because some developmental things is associated with that. So whether the brain wiring will take that much load, so whether we should practice or not practice, that was my question is. You guys understand?
So,
If you're
as I
comfortable, you
told
take
you,
the mother language and the one.
if
Okay,
a
go
child
ahead.
is having a very low word output and if he's
Mhm.
got any receptive language issues, then we can stick to one or two languages. But if a
Right.
child is very comfortable, there is no rule that you have to stick to one or two languages.
I got it.
Please go with the child's flow.
Okay.
In fact, it will help for the cognitive development.
Yes.
Okay. Okay.
Absolutely true. Thank you, Dr. Harikah.
Thank you, ma'am.
So we'll move on to the next session by Dr. Reena Jain. Before Dr. Reena takes over, I'll tell you one incident. Yesterday, I got a message from one of my doctor friend. Her son is an autistic child with ADHD, and he is about 12 years old. So he's entering his adolescence. Of course, having a child with autism and ADHD is a huge emotional turmoil for the parents. So yesterday she's a very close friend of mine. She just dropped one message. Chachkoalanundi. That means I just want to die. You see, a child with autism and ADHD itself is a big challenge, and having them in an adolescent age is like a double bonanza. Don't know how many things they have to handle. So Dr. Reena Jain will enlighten us on this topic. Reena Jain is our EB member of the Ecdforum, and she is a developmental pediatrician from Chandigarh. She heads the Government Rehab Institute for Intellectually Disabled Children, and they handle children across the lifespan from infancy to the adulthood. And she's the right person to highlight all these issues and give us a solution. Over to you, Dr. Reena. You can share your screen. You're a co-host now. You can share your screen.
Yes, yes. A very good evening to everyone. So I will just share my screen, and I think it is showing that host has disabled attendee screen sharing. So
I'll check again.
okay. So meanwhile, I will start only because we have time constraint. So what are the questions which comes to one's mind, whether a parent or a therapist or a doctor, that why should we talk about adolescent particularly and differently in autism? So because there are four questions in everyone's mind, because we want to know if adolescence is any different in neurotypical versus any autistic child, then what happens to the core symptoms, because every parent will ask ki madam abhi core symptoms are going to increase or decrease, or will they remain the same? What are the other challenges the child is going to face during adolescence, and what is the intervention program for the same?
Okay.
So
Try sharing.
okay, I'll try to share. Still not. Oh.
I have made you the co-host.
Is it?
Yeah.
Okay.
Yeah, it's coming.
Yes, I am able to share. So can everyone see? Okay.
Yes. 1 second.
So these are the four questions which comes to one's mind whenever we are talking about adolescence, right? So what is this adolescent thing? It is a biological storm because it is a period of rapid biological, cognitive, and psychosocial change, which is marking the shift from childhood to adulthood. So autistic children, they reaches puberty at the same time as the neurotypical peers, but they are lacking the psychosocial resources to cope up with the sudden physical demands. So what happens is the neurodivergent kids, they have their thinking according to the Piaget's theory of development. Their cognitive development generally stops at pre-operational thinking or the sensory motor.
Dr. Reena, 1 second. You're sharing the wrong screen. Please share the PPT. You're sharing the Zoom meeting screen itself. You're not sharing your PPT.
Second. Okay. It is not showing only. I think it is entire screen.
Dr. Anitha, can you share from your side?
Yes. Is it visible
Yeah.
now? The
Yeah. Now it's
Yes,
visible.
yes.
Now it's
Okay. So what happens is the autistic children are reaching the puberty at the same time as the neurotypical peers, but their psychological development is still not reaching the abstract thinking, which needs generally reaches the development during the adolescent age group of neurotypical peers. So it is seen that their thinking is stopped at sensory motor or pre-operational thinking, whether the IQ is more or less. But if the child has a lower IQ, the problems will be more. So, what are the core symptoms in autism children, and are they going to persist in adolescent age group? So, it is seen that beside there are improvement in children with autism during the early intervention program, but still the core symptoms remains the same or sometimes increases in the following domains. Like in physical or sensory, the sensory sensitivity may worsen, which is leading to new bodily sensations, and it can be really disturbing or scary. Social, also the peers, the neurodivergent kids, they would want to uh, socialize with their peers. They might want to socialize with their peers, but they are not able to cope up with the social rules, and it becomes even more difficult, like the sarcasm, flirting, unspoken hierarchies, they are not able to understand, and there is increased risk of being bullied or taken care of. So they don't have any understanding of boundaries. Emotional concerns, there is intensified emotional challenges, turbulent feelings leading to anxiety, depression, or self-harming behaviors, and even executive functions, as we already talked, because they are not developing the abstract thinking. So it is leading to poor academic performances and poor time management. So, what are the different challenges which they are facing toward the adolescent age group? That is, behavioral and emotional challenges like increased aggression, mood fluctuations, like there can be highly irritable, depressed, or completely silent during this transition, and social complexities from childhood to more complex adult social expectations they might not be able to follow. So one more important aspect is sexual maturation, which is going to happen according to the age. So there is internal regulation. Many adolescents with ASD struggle to comprehend, manage, and appropriately express their newly emerging sexual feelings. So they may indulge themselves in even more maladaptive behaviors and sexually inappropriate manners. Obsessive behaviors, common reports include an obsession with touching or stimulating genitals more in boys and breasts in girls, sometimes occurring in public spaces. And we are going to talk about the intervention also, that how to manage these behaviors. There can be sensory or physical pain, girls who are experiencing the menstrual cycle pain, and they may not be able to comprehend the similar thing to the parents or the teachers, and there can be a problem with the maintaining hygiene and sanitation. So the educational challenges, it could be secondary school and colleges. The child in the early education remains with single teacher or the special educator or a one class teacher. But as the education grows, the child is going to secondary school and colleges. There are going to be different subject teachers for all the subjects, and child might not be able to, the adolescent may not be able to connect with all the teachers, and there will be educational laidbacks. So there can be lower reading comprehensions, even the children who are having higher IQs, but in higher classes they may feel lower reading comprehensions. Most kids will have no formal education or formal vocational training. We go for the formal vocational training at our institute, but most of the kids will not be able to complete that. Fixed interest, lower IQ stereotypes, and maladaptive behaviors may further limit their educational and vocational opportunities. Mental health challenges can be variable from anger outbursts to physical aggression. There can be psychiatric comorbidities like self-injurious behavior, self-talking, restlessness, and anxiety. But there are sometimes either diagnostic overshadowing or diagnostic masking. So one may not be able to identify the psychiatric comorbidities very early and may not be able to treat on time. So, what are the management strategies now? I will not be able to talk about these things in detail, but I am trying to touch to each topic. So, first of all, we have to talk as early as possible to the child, and we have to begin the conversations about puberty so that it reduces the anxiety. Because we all know that autistic kids, they like to be in prediction, and we have to make the transition smoother. So we tell them beforehand and prepare them for the same. Second thing, we have to be very direct about the body parts and simple, clear instructions to be given. We should not be using vague names of different body parts, or like we want to use the term masturbation, so we have to use the same word. We don't want to confuse the child with different terms. And visual supports are very, very important. As we know, the autistic kids are visual learners, so we have to tell them social stories. There are many kind of social stories available in market, and one can make their own social stories, that how monthly cycle ends and then the new periods comes. So we can tell them about these things in social stories, visual schedules for hygiene, and pain charts can also be explained via visual cues. Then comes the behavioral support. First of all, we have to maintain the routines and we have to respect their sensory needs. A more important thing is the response interruption and response redirection, which I was talking about. What happens is the child may be doing any socially inappropriate sexual behaviors in the classroom, also maybe in the public spaces. So what we have to do is response interruption. We have to interrupt the child politely. We have to say, this is not the place you can do this. We have to tell them what is the safe space where they can do it. They can go in a washroom, but not in a public space. They can be doing this when they are alone. So we response interruption and response redirection. We have to tell them something. We have to redirect them to a activity which involves both the hands. Sometimes what parents do, the biggest mistake is they will redirect them to do some activity which can be done by single hand. So still they are engaging in the sexually inappropriate behavior. So we have to make sure that both hands are used in the redirected task. Other thing is social skills intervention. We have to foster self-awareness. We have to keep simple goals and structured goals. social behaviors can be taught by modeling and role plays, which goes throughout the lifespan only, and abstract concepts, because their abstract thinking is not yet developed, so we can make it into the simple things. And there are many supports they will be needing during the school, home, and community. So the basic model should be strength-based approach, focus on the teens' competencies and interests rather than just fixing the deficits, and transition planning earlier, because for autistic children, like when parent comes to us for early intervention, or the child 6 years, 7 years, they can see we have a lot of time to improvise. We are going to work on the child. Child can be completely normal also. They have these kind of expectations. But when child comes to us at 12 to 13 years of age, then it mostly comes to the functional academics and the functionality of the child. We have to explain to the parents that what is the expectation after the child. We want the child to be independent, right? So it can go from pre-vocational training to vocational training, and then placement in a typical different kind of a job, which they can actually, the repetitive kind of jobs in which we place autistic kids. So early career explorations are important, because wasting a lot of time in academics maybe not be apt for these kids. Skill assessments and independent living training making adulthood less frightening. So the takeaway is, while the transition is challenging, it is a normative biological process, and success lies in early preparation, specialized training for caregivers, and a supportive environment with that treats the adolescent with dignity. Thank you. If there are any doubts, I am ready to take it, and I will stop sharing.
Yeah, there's one question for you, Dr. Reena. What to do if an adolescent with autism touches his genitalia inappropriately at public places and relatives in spite of repeatedly explaining him? John, not just touching, we have seen many autistic children masturbating also in public places.
Yes, like reactions. Yes. So, multiple explaining which we have to be using with the visual cards, and carry those visual cards when you are taking the child, the visual cards or the social stories which you use to explain them. And also sometimes the sensory, which I have seen a lot of times during adolescence, the sensory needs also increases. So sometimes it is not just hormonal or sexual. The child might be actually requiring for the vestibular and proprioceptive inputs, and they go back to the same place for receiving that kind of input. So increasing the heavy activities, proprioceptive activities, vestibular activities also helps. And other than that, preparing the child that before leaving the home, telling them that we are going to a public space, the public place, and you are not supposed to do this. Instead, we can take the parents can take some of the activities which the child is actually interested in. So those activities can be taken along. But yes, sensory therapy in a way, sensory integration of vestibular and proprioceptive and tactile also helps a lot.
Yeah, that's what I was about to ask. Is the exploration of genitalia linked to the tactile sensory issues also?
Yes, sometimes it can be. Most of the kids, when we are only thinking in adolescence about the sexual and hormonal desires, sometimes it can be sensory issues also. So if we manage that also alongside preparing the child with visual support system and behavioral intervention, which I told, this response interruption, the interruption and redirection, that is also very important.
Dr. Kashumbi Basu is asking, just came across a parent wanting hysterectomy for an adolescent with severe autism. What is to be counseled?
Looking for a
hysterectomy. Hysterectomy for an adolescent with severe autism. What would you counsel? I think Dr. Reena lost.
Tricky question.
Tricky question, right?
Practically, it is safe for a mother to handle a child so that sexual abuse can be managed.
I'm really
But at the
sorry.
same time,
My hello. Yeah. Actually, my laptop, it was discharged, so the connection went off.
so can you read the
question
second
is,
question, Reena?
Yes, yes, yes. They have asked for hysterectomy. Actually, that is
Parent.
completely the parent's choice.
Yes.
This has nothing to do with the doctor's choice or the therapist's choice, because it is the caregivers who have to manage. So, we are at from the other side of the table. If you are asking for an answer, then I would say that we don't have an answer for this. This is completely uh, a parent's choice in this case.
And that too, it is a case of severe autism. So it's
Yes.
completely up to them.
Yes, yes, yes.
Yeah, because severity goes in the disability where it is going to be dependent on someone for the rest of the life. So, though, as Reena said, it is better to go along with the parents' choice, whatever they
No,
feel.
actually, what the I sent, like I counseled, and then I sent to a gynec friend, and she sent her back to me again. Like, what is the indication? What are you going to? How are we going to avoid a medical legal case? That is what she wanted me to write on paper, but I don't know what
That's
to
not
write.
possible.
Actually,
Actually, that case being an adolescent, you said, an adolescent, we can't take the decision, number one. And number two, hysterectomy is a big thing, so you cannot, you can maybe probably you can opt for a tubectomy instead of hysterectomy.
And
no,
also,
actually,
There has to
no,
be
actually, there are
actually, that
many
valid
medical
indication
legal
for
tubect.
that.
things attached to this,
Yes,
because
Yes.
if there is any kind of sexual abuse, the parents will not be able to get to know. So it's actually a very sensitive matter, and we will not be at any point of time be able to tell them to go for it. It is completely their decision.
Their choice.
No, even if it is their decision, like the surgeon operating has to have a valid indication, isn't it?
Absolutely.
Yes,
Absolutely.
And
absolutely.
only tubectomy is not helping with the
Yeah, it
periods.
won't help with the
Mhm.
So
periods.
that is, and she needs significant help in each of her daily activity. So that is what. Then I suggested ki we do not go for a surgical hysterectomy. Maybe we could manage with some medical
Medical.
at the time for the time being, but I don't think that is going to help for the rest of her life. But let's see
Mhm.
what can be done. It's a difficult situation.
Situation.
Progesterone
Any
implants
surgical
can be given.
any
So the
surgical intervention needs to have an appropriate indication.
Patient. Yes.
Exactly,
It
exactly.
cannot be on the wish of a parent that they are suspecting something which has not yet occurred, and they are in the anticipation of that it can happen, and they are going for it, and the
Exactly.
surgeon
No,
will
no,
do it.
it's
Very
not just
difficult.
No,
the
but
abuse.
it's
That
not
is
It's
that
not
why.
just
they
the
want.
abuse. Even in
Actually,
the
And it is
menstruation needs to
and it is
managing
happen.
also
periods,
Yeah,
managing menstruation in a
menstruation.
like adolescent girl
Severely
can be
autism.
very
That is
difficult.
the girl is a severely
that's a
autistic.
legal thing, that will come in, and it will be very difficult, for the surgeon
Mm.
to give a proper indication why it has happened.
Yeah.
Exactly. That is
So it
why
has
the
to be,
gynec also
taken
sent
with a
back.
caution. Yeah.
They want a valid indication, isn't it? They cannot just operate on the wishes of the parent, and that to a like a surgery like hysterectomy. That is difficult.
Probably
So
they
in
should
that
approach the
case, the parents
board of
has to go to
medical
the
board.
court and
Board.
get the permission.
Yeah.
Yes.
Court,
Yes,
get a medical
they
board
have.
approval and
Yes.
then go for it.
Even for the court also, it will be very difficult, for
No,
this to
there
decide.
are many grounds.
Yes,
Like
there
for
are.
parents, they can do it. It's not that, but they have to take that yes from the
Pain.
court, not
Yeah.
from
Yeah.
us.
In that
Hmm.
context, gynecologist will be on the safe side because she needs to have an indication to go for
Absolutely.
surgery.
Absolutely.
They will be safe. Unless you give that assurance, they are not going to operate on an adolescent that too. That's
So
very true.
refer to court
Yeah.
for higher management.
It's a
Now they are
difficult.
dealing
It's a
with an
very difficult
adolescent with
phase.
autism, and then again
It's
a
a.
court. Like it's a very weird
Mm,
situation, isn't it?
True, true.
mm,
That's true.
Yeah.
And these are the people who fall into the trap of the quacks also. Like unqualified surgeons, they go to them and get it done.
mm.
So that is a very
So,
tricky.
right counseling of the parents is very much required from our side, so that they don't fall for all these things, and they might get into some kind of trouble. So it's better that we tell them in detail everything, and show them the right path. Actually, we can tell them, if you really want this to go, you can write a plea to the court and the medical court.
Actually,
So
Reena and Koshambi, I tell you both that this age, at that adolescent age, the pitfall is that the parents do not come to us. Instead, they go to the psychiatrists, and they are mainly managed by medicine. They become dependent on medicine. They don't come to us for counseling or even like this. We only discuss, but all things are just managed by the respective gynecologist and everything, and psychologists and psychiatrists don't come to the pediatricians. And people think that after 12 years we cannot do anything. So we don't get these age patients rarely, even only they are in a relative connection or like this. Otherwise we don't get at that age.
Yeah, they don't come straight away to us, but if the child has been following up with us since infancy as a pediatrician, then they will ask you this
sir,
question.
we have more than 100 kids, autistic adolescents with us in our school and clinic setup, more than 100. So if they are following us in the same institution, they are going to come. Till 18, they are going to come.
Yes.
The terms and condition apply again.
Yes. So now we are done with adolescence. We'll move on to the adulthood. So we'll have many questions like, is this autistic child growing up, and does he know his sexuality? Does he know his gender? Can he be sexually active as a normal person? Can he be a family person? Can they reproduce? So all these questions will be there in their mind. Dr. Ketaki, we welcome you for this session. Ketaki is our EB member at Ecdforum, and she's a developmental pediatrician based in Pune. She's a child and adolescent counselor also. She's the director of Sri Ganesh Building Blocks ADC at Pune. Over to you, Dr. Ketaki.
Thank you, Anitha ma'am, and I welcome everyone to today's session. So my topic is really very, very sensitive, as it is autism itself. We are still working on awareness. We are still working on parents to accept that, autism in their child. And on top of that, imagine if autistic child having a challenges with gender and sexuality is a tremendous pressure. Not only parents, I'll say the other side of a table also, as a developmental pediatrician, psychologist, therapist, because I feel that community doesn't accept. So my topic is about gender and sexuality in autistic individual. So we all know by now what is autism. I want to read it again because then only we'll understand gender identity problem or sexual orientation challenges in children. So autism is a neurodevelopmental condition where there's a problem in a social interaction, communication, and behavioral issues, either due to emotional dysregulation or due to sensory integration challenges. Even just now Dr. Reena said, gender and sexuality is like a natural part of a human development. So all autistic children develop normally with a gender and sexuality. So all of them will have their own gender identity, need of having their own gender identity, connection, relationship as everyone else, like a neurotypical children. So let's understand the terminology. Sex is like XY and XX chromosome, biologically given by God. At the time of birth, it has been assigned as a male or a female. Gender identity is how a person feels internally. So there's no medicine to change the feelings. So gender identity is how a person feels internally. Gender dysphoria is when there is a mismatch between sex and a gender identity. And sexual orientation is who one is attracted to. So gender identity is about who I am, while sexual orientation is about who I am attracted to. So here we see two different things. One is about a gender, which is a feeling of whatever a person feels about gender, and other one is a sexual orientation. There are many other things. I'm going to cover only these two, which are most common. So let's understand what is the prevalence of gender diversity in autism. मतलब gender diversity कितना common है autistic बच्चों में. So compared to general population, gender diversity is approximately 0.1 to 1%, but it is more seen in autistic children, 3 to 6 times more likely to be seen in the neuroatypical children. And around 5 to 6% of children with autism shows gender dysphoria or gender identity concern. But ये होता क्यों है फिर autism में? Why the prevalence is so high? It goes back to the definition. So why this happens? Reduce social condition. So we all see normal children during like 2 years of age. By 2 years, all children can understand. बोलने लगते कि मैं लड़का हूँ, मैं लड़की हूँ. They understand their sex. Preschool age में they start understanding gender identity. Not only about themselves, about surrounding also. तो हम लोग देखते प्री स्कूल एज के बच्चे they play a lot of pretend play, imitation होता है. That's how they understand and learn about the surrounding लोगों का gender identity by external appearance. Voice हो गया, कपड़े पहनने का तरीका हो गया, बाल हो गए, all the mannerism they understand that male and a female, and that's how they learn things. But what happens in autistic children? There's no imitation. They hardly play pretend play, and they're not involved in the surrounding. So they don't, go with the social norms. So autistic individuals are less influenced by societal norms, also less influenced by societal expectation. सो ऑटिज्म को हम मराठी में बोलते हैं स्वमग्नता, जहाँ पे बच्चा अपनी दुनिया में इतना खोया है, ही इज नॉट रिलेटेड टू द other world. So what happened? He's not worried what the societal expectation are, what are the normal societal norms are. For example, a 10-year-old, this is very common, OPD में आते हैं ऐसे cases कि 10 साल का लड़का है, mother is worried that he's all the time dressing up like me, he wants to copy me, he wants to wear bangles, साड़ी पहनने का है या दुपट्टा लेने का है, नेल पॉलिश लगाने का है, and we try to rectify, try to tell him that not to do this because you're a boy, but he says I like this and it's right. So unlike neurotypical children, he's less pressure by what boys should do. So because of a reduced social conditioning, this can happen. Now the second point is cognitive style. So we all know as a society or a community, we are very rigid with the sex and a gender. So these children are rigid with once they learn rules. उनके हिसाब से एक चीज होती है black and white. For them, it is very difficult to understand the gray area. So when we talk about a gender, I said it is a feeling. So for them, it's difficult. So they tend to question rigid categories like gender. So analytical thinking करके they can ask questions about the binary ideas. So I'll give an example. 12-year-old with a high functioning autism asks, why are there only two genders? People can be different, right? So this reflects logical questioning of rigid social construct, not a confusion. So next is a sensory factor. डॉक्टर रीना ने भी मेंशन किया कि एडोलेसेंट में सेंसरी प्रॉब्लम की वजह से किस तरीके से presentation हो सकता है. So I'll give just an example. Adolescent female who's in a menarche and she refuses to wear tight innerwears, and now she's bleeding also in the menstrual cycle, and she hates her body because she's not comfortable with the clothing or the menstrual thing. So it's not necessarily gender dysphoria. So these factors really do not cause a gender diversity. कि इसकी वजह से बच्चे को कंफ्यूजन हो रहा है कि मेरा जेंडर आइडेंटिटी क्या है या मेरा सेक्स क्या है, बट they influence how it is experienced and expressed in individual autistic individuals. So how sexual development happen in autistic children? So they experience puberty, curiosity, attraction, but the challenges are, Dr. Reena also mentioned, is social understanding. We know that autistic children, चलो speech आ गया, language आ गया, Next comes the communication skill. Next come understanding the higher level of language, where we talk about the pragmatic communication skills. तो यहाँ पे problem क्या होता है? They don't understand the double meaning sentence. They will not be able to understand sarcasm. They can misread the signals like flirting or interest. So, the last question was कि publicly the child was masturbating. So they don't understand public and private things. So there's a confusion. Because they are not able to express, there is a communication skill problems. So they are at a high risk of sexual abuse, and they don't understand the boundaries also. So literal thinking and sensory sensitivities are mainly the challenges in autistic individual. So as we know that autistic individuals are 3 to 6 times more likely to report gender diversity. Now let's see what exactly gender diversity में होते क्या क्या चीजें हैं. So high rate of non-binary identity, gender fluidity, same sex attraction and asexuality. So यहाँ पे again दो चीजें हैं. एक है gender identity का problem and the other one is with the sexual interest. So gender identity में non-binary identity and gender fluidity, and sex orientation में same sex attraction, that is homosexuality and asexuality. But the most important thing is not all the autistic children will have this problem. In fact, most autistic individuals are still cisgender. Cisgender means जो उनका sex है, they feel the same gender identity. So let's talk about non-binary identity. So non-binary identity is a gender identity where a person does not identify strictly as a male or a female. So sometimes like both the genders, they'll say neither a gender, somewhere in between. So gender is not limited to two categories for them. So for example, a child can say that I'm not a boy or a girl, and that is a concept they have. So what do we do now? Parents आते हैं ऐसे सवाल लेके, या फिर even if we have parents in the group, so what do we do with this non-binary identity concept of a child? So we accept without a judgment because it's a feeling. It's not a disorder, it's not a disease, it's just the feeling, and we just have to accept without a judgment. And we have to respectfully ask about the comfort preference कि आपको किस नाम से we can address you, pronoun क्या करना चाहिए, what do you feel. So focus on therapy goal. Therapies are not going to correct this non-binary identity concept. Therapies are for the autistic जो भी problems होगा, sensory होगा या gross motor में होगा, any other anxiety along with that, if any other problem is there, the therapy goal are for that. And we have to educate parents to stay calm and supportive, which is the toughest job to do. And obviously we have to avoid forcing labels and dismissing the child because of a non-binary identity concept. Next is gender fluidity, a gender identity that changes over time. So this can happen normally while child is developing, but after 7-8 years, then it is difficult. A person may feel that I am a male sometime they feel I am a female, or sometimes they will feel I am neither of it. So gender here is dynamic, it is not fixed. So adolescent can say I hate my body and I don't want to be a girl. I'm just giving an example. So what do we do if a child is have a gender fluidity कि कभी मैं लड़का हूँ, कभी मैं लड़की हूँ, कभी कुछ भी नहीं हूँ, मैं कुछ और ही हूँ. So what do we do in such case? Again, imagine gender identity या gender dysphoria में मैंने बोला था कि there is a mismatch between sex and gender identity. So for them, it is so difficult to come to the terms with their own identity, and there's a really genuinely distress. So we have to take it seriously. We have to validate their feelings, and we have to see if they have anxiety or depression because of this challenges, and we have to give them enough space to express their emotion. And we can refer to psychologists or psychiatrists if this gender fluidity is creating a lot of anxiety or depression. We need to support parents also. And what do we avoid? We avoid ignoring their feelings, saying it's just a phase and taking it casually. So that is a gender fluidity. Now we talk about sexual orientation. So homosexuality is something we are very aware of, that a person is attracted to individual of the same gender, male attracted to male, female attracted to female. This is about who they are attracted to, not their gender identity. So here also we normalize feeling, provide a safe space, and again assess if they have anxiety, depression because of a bullying and other things. We have to support parents, we have to support children. Do not dismiss as a phase, avoid trying to change orientation, and never shame or force suppression of feeling. So, this will fuel up their anxiety and depression if we keep shaming them or forcing them to change their feelings. So, this was homosexuality. So asexuality is something where autistic children they're not interested in a no sexual attraction. But the problem here is they can come across as very cold people. They're not, people assume that they are not interested in relationship. They do not want companionship, or they don't want any romantic relationship, and which is abnormal. So it's not the case. A sexual orientation where a person experiences little or no sexual attraction to others, important thing is still they want a form of a emotional or romantic relationship. They desire companionship. So what do we do? Normalize and respect the experience, reassure that emotional bonds are valid, assess only if there's a distress or confusion, support both individual and educate parents, avoid, do not label as abnormal, avoid forcing expectation of sexual interest, and do not assume lack of emotion or relationship needs. So what are the red flag sign? This is, as I said, this is not a disease or a disorder we need to work on. These are just feeling, and this is what they're naturally born with. So, but when do we do intervention? So the red flag signs are if a child or individual is trying to harm, self-harm, and harboring a suicidal ideation. You notice a severe depression, there's a school refusal, extreme body hatred. And how do we do a clinical approach to these kind of challenges? Take a neutral or non-judgmental stance. Even I'll say parent or a therapist or a doctor, we do not need to judge a child. Longitudinal assessment, if the challenges are persistent, consistent, leading to distress. Multidisciplinary approach, SOS, if required. Parental counseling is the toughest one. It's not easy to tell that, it's okay if your child is homosexual, it's okay if your child is by sex, is a boy and he wants to be a female, because their expectation when they are coming to your OPD or going to a therapist that कि मैम इसको समझाओ ना कि ये ठीक नहीं है, he's a boy but he's trying to do all these things. So acceptance from parent side is also very tough, and it's not easy to counsel them. Personally, I had gone through this, and I just tell them one thing, that a child's gender or sexuality is not everything. It's just the part of life. There's much more and beyond gender identity or sexual orientation. So we have to focus on strength of a child rather than focusing on these challenges. And Dr. Reena has already covered sexual education. We have to teach them boundaries, good touch, bad touch, consent, private and public places, things like that. So she has already touched upon all these points. I will not go again. So what are the myths about autistic children and sexual development? Autistic people are not interested in relationship. Realities, they do have emotional and sexual need. Another one is they cannot understand a gender, but realities, many individuals have very, very clear gender identity. Last one is talking about sexuality to an autistic child is harmful. But the reality is we need to educate them, and it'll help to reduce the confusion and sexual abuse. So this is the most common thing happen when parents coming to you, they feel can therapy help or correct gender identity? So no, it doesn't. Conversion approaches are unethical and harmful. Focus should be on support and mental health. So takeaway message is gender diversity is more common in autism, but it is not universal. We should avoid both dismissal or overinterpretation. And most importantly, our role is not to decide the child's identity. And our role is to ensure their mental health, safety, and dignity. Thank you.
Thank you for the elaborate presentation, Dr. Ketaki.
Thank
If
you.
anyone has any doubts, you can unmute and ask. So how do you suggest if like an autistic person has sexual arousal and he goes in public and hugs someone and tries to kiss them? There was an incident. One parent came with a complaint that uska kuch karo, give him a medicine that he doesn't do it.
Yeah, so that is what I said. No, we have to teach them the boundaries,
Boundaries.
taking a consent, public versus private things. So educational sexual education is must, and we cannot say that autistic children don't need a sexual education. We have to educate. I'll say in a preschool period, we teach them good touch, bad touch to avoid sexual abuse cases, and later on, sexual hygiene and things like that. So it's precautionary thing.
Yes. So just as the takeaways, just like we educate a normal, typical child, we have to educate an autistic person also, considering the fact that they do have sexual feelings and they may go in for sexual relationships. So precautionary and appropriate behavioral modification is very important. Training is very important to set the boundaries and socially appropriate behavior.
Yes.
Okay, thank you so much. Now we have come to the adulthood and life is a full circle. We'll go back to the infancy. We'll go back to the infancy and see how a young child would like to communicate with us. So, I have a few kids who were diagnosed with Down syndrome at an early age, at birth itself. So, some come for home-based therapy plans. So, some are following up. So, there were a few kids who are in the months age. So, when I tell them that, are you communicating with your child? Are you able to, are you doing it on a daily basis? And they said, what do I do with a 4 months or 5 months kid? Do you think they understand anything? What can I do with them? So this answers will be dealt with by Dr. Nilanjan. Dr. Nilanjan is a president of our Ecdforum. He is a senior developmental pediatrician and heads the Shishu Mangal Child Development Center. Over to you, Dr. Nilanjan. Dr. Nilanjan, I have made you the co-host. Would you like to share your PPT?
Yeah. Am I visible?
Yes, sir.
Okay. Okay.
Yes, your
Now,
screen is visible.
yes.
Please go ahead.
Okay. So it is a pleasure to talk in front of a good audience. I have a little bit throat problem, so probably it may be choked in the middle, and it is really nice to see a few mates of my ECDCon 2025 Kaushambi ko dikha aaj. So it is very good to see her. Uh, Again, I'm coming back to the childhood after a long discussion on adolescents and their sexuality problem. So prelinguistic behavior, which is the before starting phase of speech in case of autistic children. So it is early communication in children begins long before they start using words. So communication starts as early as 3 to 4 months even, because that cooing, babbling, everything is one mode of communication. Basically, after the first cry, whenever the child is born, after the first cry, the every cry and everything the child is making, it is for one kind of communication. So babies and young children connect with others through eye contact, expression, sound, and simple interaction. These early behaviors help them build relationship and understand the world around them. Initially, they know only their mother, but afterwards, it is the whole world surrounded them, and this is totally. So the children with autism, these early communication patterns develop differently, which can affect how they engage socially. So what is prelinguistic behavior? The prelinguistic period of communicative development refers to a group of behavior that children use prior to the meaningful use of word or gesture. So before using the word, so communication comes first, basically, not after this speech and everything. So whenever parents come to us with speech problem, basically we have to know that whether the child does communication or not. So if communication is not there, a back and forth thing is not there, reciprocation is absent, it is very difficult to start speech. So what are these word or gestures? This include eye contact, facial expression, gesture, sound, and responding to others. These early behaviors are very important. So stages of communication according to development. First is eye gaze. Eye gaze starts as early as 1.5 months, because whenever the child is born in the initial stages, the child only gives a vacant look and not fixing his gaze to anything very specifically. But whenever the child grows on 1 to 1.5 months, it fixates up to the distance of 1 meters and then moreover. So first is eye gaze, next is joint attention. So it is again in the one part of communication, facial expression, imitation, social emotional affect, and adding gesture and non-verbal means. So using some gestures. Now various prelinguistic behavior, what are they? Imitation, looking and listening, turn taking, joint attention, anticipation, understanding, engaging others or acknowledging interactions, that is smiling. So social smile, which starts as early as 1.5 months. This is the, I think it is should be the most and foremost part of communications. Whenever a child looks at the human face, it starts, according to Erickson, at the age of 45 days onwards. So looking and listening, according to WHO, listening should be ascertained as early as within 1 month of life. That is by OAE. So listening should be there, and if it is there, then the child moves his face towards the source of sound, and some change in the mouth, which tells us about the child's intelligence, cognitive part, and also the smiling at 1.5 months, it tells about the communication part. Impaired prelinguistic behavior in autism. Now, I just now discussed about the general child. Now, coming in case of autism, the main three things which are absent is eye gaze, gesture, and vocalization. So, at early as 4 to 5 months of age, after cooing, babbling, the vocalization starts, which is one very important part of communication, early stages of communication. through which the child starts to communicate very specifically. That's looking at that part, that people whom he wants to connect, and connects with it through vocalization. So the earliest recognized communication deficit is delayed or absent joint attention, may be evident in the first year of life. This is nothing but, sorry. The screen sharing has.
Yes, sir. Any problem?
The screen sharing has stopped. Let me share again. Yes.
Yeah.
Okay. Okay. So, yes. So the early social communication deficits in autism, the earliest deficit is absent joint attention. Second is that two kinds of pointing we know, that is proto-declarative and proto-imperative. So pointing and reaching to something which we know in case of autism. This pointing and finger leading, which stays up to the age of 2.5 to 3 years. And it is a very pathognomonic feature or salient feature of autism children, that finger leading is almost present in more than 90% of children. And they use only this thing, that they hold the hands or two fingers of the caregiver and takes away and moves away to that part. So pointing and reaching does not emerge at expected time in autistic children. Because whenever...
1 minute, sir. Can you make it full screen?
There's some problem in the screen, I think.
Okay, sir. Let us go ahead. Let's continue. No problem.
Okay. So requesting proto-imperative joint attention, requesting or proto-imperative joint attention, which involves the child use of gaze shift, is usually disrupted. So proto-imperative and proto-declarative. Okay. So this is joint attention, which is to share an experience, is severely hampered. That is the most important part of communication is hampered. Aims of early intervention strategy. Now, what to do in this case? So attending to others' face, voice, and action, learning to use and understand speech, verbal imitation. Imitation is very important because there also comes that part of cognition. Without sound cognition, the imitation will not be there in up to the level. So there may be a dilemma in diagnosing of autism with or without intellectual disability, because if the cognitive is not present up to the mark, then imitation also may be impaired in additive amount in case of intellectual disability. So verbal imitation, sharing emotion, need and interest with others, playing with toys in typical ways. So I am not going to discuss the details of how many types of play are there, because we know that initially there is solitary play, then is sharing play, parallel play. There are so many types. Last coming the pretend play, put together and pretend play. So activities to improve prelinguistic behavior. So what are the activities we should encourage? Keeping things at face level. So it is the naturalistic approach of our new concept of therapy, that whenever in case of starting of therapy, the child who do not have good amount of communication, always sit or come to the level of the child, because the child is not at all motivated to look up, and we are in a above height, and child is not motivated to above level, because the child is just engrossed in self and keeps himself very indifferent. So whenever you come to the level, eye level of the child, only they will be able to see at the face to face. Blowing bubbles, singing rhymes, we all know these things. Therapists use this kind of play materials there, and lighting toys, candles, and hand puppets or dolls. Now, improving social attention. So there is, the previous one was eye contact. Now is social attention. We know the two things are deficient in case of autism. One is social attention, another is social understanding. So I am not going to discuss about the understanding. Now it is social attention. First is join in. So the child is playing, maybe it's solitary, maybe isolated one corner of a room. So join in the action, copy child's action. So first you imitate the child and then only the child will be interested in you. So keep following the child's lead. So the best way is taking two uh, toys in a hand and let the child select from that. And then only the child will be interested. You cannot select yourself and give to the child. So keep following the child's lead. Catchy phrases. So very one or two things very fond of children. So you should coming the phrase that jump over, laugh at, or something like these catchy phrases. You can use these things. Teaching joint attention. Initiate sound or surprise. Interact through time delay and face-to-face games. So these are all for communication. You see, communication, if it is not present, joint attention is looking to a common thing which we both look at a place and again we आंखों में आंखें डालते हैं. So आंखों आंखों में बात होता है. So this is the joint attention. For this we have to initiate sound of surprise because otherwise the child will not be interested. He is very much reluctant to look at your activities. Now teaching imitation. Facial expression, funny faces. So you can use that mask or something like this. Imitation with toys, gesture and action songs, physical prompt. Teaching turn taking. So what is turn taking? The peer play, turn it around. We can do this ball games or make in a row that first let us do myself and then you will do. The child will know the wait time. The waiting time they should know and the turn taking will appear there. But it is more important in case of ADHD child because turn taking is very difficult in case of hyperactive child. So peer play, turn it around and stacking rings. We all know that these things going extended and flexed things. Now general strategy, reduce screen time. Yes, these are the main strategy we should tell the parents or caregivers on the very first interaction. That is reduce screen time, time devoted for the child. It is the most difficult thing nowadays because whenever even we both come at home, parents, so they are all busy with their own screen time, not with the child. Minimal instruction, visual aids. We have also an instruction counting notebook. We applied this 3 years back and it has made a significant change in case of children. Initially, we instructed the parents to count in this instruction notebook and they were really astonished to see that per day parents make near about 350 instructions to the child and to minimize it within 200 it took almost 1 month. So minimal instruction is very important and this paper was published in our International Developmental Conference in Philippines, Manila in the year 2019 that less instruction helps to improvise or improve the expressive language. So visual aid, simplify language. This is very important. One thing is not mentioned here, that is there is single language. So there is two languages used in Bihari लोगों के साथ किसी तमिल का शादी हो गया तो they use their own language कभी कभी जो मन में आते हैं करते हैं. This not should happen in front of the child because at the learning phase the child will be very much confused. We know all this. So coming to the conclusion, prelinguistic behaviors play a key role in building communication and social interaction skill in early childhood. In children with autism, difficulties in these areas can be seen early, but with timely intervention and supportive activities, this timely is very, I mean, sleepy term because today also two children came with their parents at the age of 3 years, 4 months, and one is 4 years, 1 month. So this is the average age 2 to 3 years when the children come. But if we could get them as early as 1.5 to 2 years, I think it will be the exact timely intervention and supportive activity. These skills can be improved. Simple strategies like encouraging eye contact, imitation, and turn taking can make a big difference overall. Early understanding and support can help children develop better communication ability and meaningful social connection. So thank you for patient hearing. Before ending, again, I would like to thank Dr. Anitha for this excellent moderation. I introduce not, I'm just telling that Anitha is going to organize one big national conference again in Hyderabad. That is the second edition of our ECDCon 2026. So I request and invite you all to this event, which is on 21st and 22nd of November 2026 at Apollo Hospital, Hyderabad. And
1 second, sir. If you stop the share, I'll share the flyer.
yeah, sure, I will do that.
Thank you.
Okay, I have stopped. And again, one thing I wanted to add that our next webinar on the same thing, not on the same topics, but the second part of this autism conference, Autism Awareness Month, will going to happen on 23rd of April. So please be present and also share a lot in your friend groups. 23rd of April from 9 p.m. The second part or second episode of this awareness program will go on. There will also be 4 speakers. So I invite you all. Thank you.
Thank you, Dr. Nilanjan ji. The takeaway home point is connect, communicate, and then comes the speech. Thank you for the wonderful roadmap which you have given. If you have any doubts, you can unmute and speak. Meanwhile, I thank all the speakers for their wonderful presentations. Dr. Nilanjan, Dr. Reena, Dr. Ketaki, and Dr. Harikah. Thank you for the wonderful knowledge you have shared. And as an organizing secretary, myself, Dr. Anitha, invite you all to Hyderabad for a second national conference, ECDCon 2026, on November 21st and 22nd. This is a 2-day conference exclusively on the early child development. We'll have wonderful hands-on workshops related to early child development and neurodiversity. Do not miss it. We have early bird registration up to May 31st. The registration fee for doctors is 3,000. So please do register.
Thank you, Nilanjan and all, Dr. Anitha and Ketaki. We made all in Calcutta, and I'm also regularly following you and increasing my knowledge with you. So thanks for inviting me, and especially with this group. And as I mentioned earlier, also, not only me, my research scholars also have joined over there, and we are learning from you. That's very good. And thanks for the early invitation at Hyderabad. We will make a point that we can also join that time. Sure.
Thank you, sir. We hope
Thanks.
to see you there. See you here
Sure.
in Hyderabad.
Sure.
Thank you. The dates are 21st and 22nd November. Done. So if nobody has any questions, we'll wind up the session. We'll meet again in the next session. We'll update you on the date and the time. Thank you. Thank you everyone for your patient listening, and thank you for being present today.
Thank you, everyone. Good night. Thank you, Anitha ma'am.
Yeah. Dr. Pooja,
Good night, everyone.
tentatively we are planning on probably 22nd Sunday. We'll share the final date soon.
Okay, ma'am. Thank you. Thank you.
Okay, good night, everyone.
Thanks. Good night.
Good night. Bye-bye.